Welcome to this eighth event speaker series from Canada India Foundation. Friends, welcome. It's an honor and privilege to introduce my friend Dr. Tarang Sheth, a very, very renowned cardiac radiologist. I'll have to read because this is impossible for me to remember all his credentials. Otherwise, I might, introduce something wrong. Tarang has pioneered the practice of cardiac radiology, has developed and directed cardiac CT and MRI program at the Trillium Health Partners. Cardiac CT and MR are advanced imaging techniques used to diagnose heart disease at a very early stage. Cardiac CT technique is revolutionizing the way to evaluate patients for their heart diseases by detecting the disease accurately and non-invasively. His expertise in this field is acknowledged globally. He has co-authored chapters about cardiac surgical imaging in Cohn's textbook of cardiac surgery. His present research is on the use of digital health technology and wearable vital signs monitor to improve cardiac CT workflow efficiency. Dr. Sheth serves as the chair of the management committee of the Trillium Mississauga Radiology Association. He also directs the Trillium and Halton Cardiac CT programs and has established a cardiac CT program at the Halton Healthcare Services in Oakville. He has attended University of Toronto and is a Harvard grad. Friends, Canada India Foundation has been organizing this speaker series and inviting personalities from different spheres of activity to talk about their areas of expertise. The purpose of this series is to conduct an outreach program to enable us to spread the message about our organization. Canada India Foundation was formed 11 years ago to achieve the following broad objectives: to foster bilateral relations between Canada and India, to create opportunities for qualified and eager Canadians of Indian origin in the Canadian mainstream, create the right profile of Canada in India and of India in Canada, organize bilateral programs to focus on bilateral such sector-specific forums that are important to the economic of both the countries, Canada and India. And of course, recognize and honor a true global Indian achiever at our annual award gala. On July 5th and 6th, we are organizing a higher education forum. You can see the signage here. This forum will be a gathering of experts from Canada and India who share a common interest in higher education platform and opportunities in both the countries. I don't know if you're aware of it, but last year, 125,000 Indian students have enrolled into different universities and colleges in Canada. Majority of them have been in Toronto area. This particular event, if you have any students in your family or relationship or connections, we would like you to advise them, inform them to register. Go to CanadaIndiaFoundation.com, register at our website. There is a bursary of four bursaries, basically of $1,000, three of them, and one for $2,000, which is a cash incentive which we are giving to the students to participate in this education forum. And the whole idea is that awareness of what Canada is doing in India and what Indians are doing in Canada to participate. On July the 6th, we have the Canada India Award Gala. This award gala, this year we are recognizing and awarding a child prodigy Spurs Shah. He's no relation to me, but the kid, if you go to his, Google him, YouTube, TED Talk, he is mind-blowing. Eminem, he has sang during one of the, the awards, the musical awards time. He has sung with Eminem. He raps in Hindi, and he also raps in English. With this kid, it's going to be a dynamic change for Canada India Foundation's platform, because the past 8 recipients that we have had, they've all been business leaders. Those business leaders have made a lot of money. They didn't need the money. This kid wants to go to University of Berkeley for learning music. It costs $100,000 a year. And Canada India Foundation is going to be very proud to at least contribute 50% of his fees for the next year. So without further ado, ladies and gentlemen, let me invite Dr. Tarang Sheth to this platform. Tarang.
So thank you very much for the opportunity to speak with you today, Anil Bhai. I really appreciate the opportunity to speak here to the Canada India Foundation. As you can tell from looking at me and from my name, I'm also of Indian origin. In fact, I was born in Mumbai about 20 years ago. No, that's a joke. I was born a few more years than that. And I came here as a little kid, about this big, and spent the rest of my life here, of course. My wife is from Mumbai, came more recently at the time of our marriage. And I have a strong personal affection for India. I think it's an amazing society that we come from. And at the same time, I've spent my whole professional life here in Canada and working in the Canadian healthcare system and trying to innovate and move the barriers of care in terms of what we can accomplish. So your message, your purpose as an organization is something I can certainly resonate with. So what I'm going to do today is I think I'll have to operate it from here. Okay, so what I'm going to do today is in about 40 minutes or so, I'm going to go over these. It's really a journey. I want to share with you a journey about heart disease and about diagnosis of heart disease. We're going to talk a little bit about diagnostic medicine, the heart and heart diseases. You all have one, I know that, because you're here in this room today. Indians and heart disease, a very important topic for us as an Indian community. We'll talk a little bit about prevention. As you know, I'm a radiologist, so it's not my area of professional expertise, but certainly something I can speak to briefly. And then we're going to talk about this, which is the main subject of my discussion, which is how do we diagnose heart disease today, as in the past 5 or 10 years, and how is that field rapidly changing under the current technologic paradigm we find ourselves in? And then what does the future of heart disease diagnosis look like? So when I entered medical school, this was a few years ago, I remember one of the first lecturers we had, he got up to the board and he wrote 2 letters on the board. And he said, when you finish here in 4 years, you're going to put those 2 letters in front of your name. But he said those letters have a symbol, they have some symbolism. And so we were perplexed, obviously, like what could D and R mean? And he said, well, when you separate those 2, they become DX and RX. And I want you to remember that because that's medical lingo for diagnosis and treatment. And he said, fundamentally, a role of a physician, what do doctors do in their daily lives and in their work? The fundamental role you can divide into 2 basic tasks. The first is diagnosis, and the second is treatment. And if you understand that, you're done, and you can go home. But no, we had to spend 4 more years and finish all of that. But the point being that medicine has 2 essential functions. The role of a physician is 2 essential functions. It's diagnosis and treatment. And without a diagnosis, you don't have a treatment, and without a treatment, the patient doesn't get better. So we know a lot about treatment physicians in the popular press and in the television series and all of that. You hear a lot about the heroic heart surgeon or the heroic neurosurgeon or the heroic interventional cardiologist because they make the patient better, and they play an amazing role. And my colleagues at Trillium Health Partners, the cardiac surgeons I work with and the interventional cardiologists, they do amazing work. But the part that the public, and that's why I appreciate this opportunity, because the part that people don't know much about is diagnostic medicine. And that's the field in which I practice, because as that statement says, and I like that, it says, without a diagnosis, there can be no cure. And I think that's a very important concept to keep in mind, because unless we get the diagnosis for the patient right, no matter what our intentions are, we cannot fix them. We cannot make them better. So diagnostic medicine is half of medical practice. I would argue it's the more important half, but anyway, we'll leave it as it is. But certainly a very important part. And that's the field in which I practice. So what are the basic methods by which a diagnosis can be achieved? So when you go to your physician and you sit in their office, they can take a history and they can do a physical examination. They do that in their office. So if there's a physician you're seeing, whether it's your family doctor or your cardiologist, this is what they'll do. They'll do the history and the physical. Sorry, I'll just back up. And then they can order some laboratory tests, which are also, of course, very useful for making different diagnoses. And then there's imaging. And that's the area in which I practice. So what does imaging mean? Imaging means something very basic, like an X-ray. And this is some technology that's been there for 80 years. Ultrasound, again, also relatively old technology, but useful for many diagnoses. And when we talk about the heart, ultrasound of the heart is done by cardiologists for the most part. That's what we call an echocardiogram. And then there's the relatively newer kids on the block. These are CT scanning or CAT scanning and MRI. And these are the technologies that I work with when making diagnoses of the heart specifically. Now, these imaging tests, if we look at how they have changed their role in medicine, their role in medicine has grown really astronomically. And particularly in the decade prior to this one, you can see that there's really been a straight line up growth from bottom left to top right. And what does that mean? It means that these diagnostic techniques of imaging have played an increasingly central role in medical diagnosis and medical practice. So previously, as innovative techniques at the periphery of medicine, they have moved right into the center of medical care, medical diagnosis, and played a very important role in how physicians can make decisions about what's wrong with the patient. And the ones that I said that I practice with primarily are CT scanning or CAT scanning, the machine is shown here, and MRI, which is magnetic resonance imaging. Now, these are very powerful imaging techniques. They're also very expensive. A CT scanner will cost somewhere between $1.5 and $2 million, same for an MRI. They have an annual operating cost of $500,000 to $800,000, so these are not cheap machines. And at the same time, they have an immense impact on diagnosing heart disease, but I can expand. I could give this talk for a whole range of conditions, including brain and spine, the abdomen, the chest, the legs, the back. So you name it, the entire body now can be examined with immense accuracy and diagnostic precision using these very powerful, albeit expensive techniques. So let's take a minute. And what I'm going to do is, so we're talking about the heart now. So we've moved from talking about the diagnostic techniques that are available to us, and I want to talk about the heart, because you all have one, as I said, and we are interested to know, before we can understand what can go wrong with the heart, we're interested to know how does it work. So the heart is actually a fascinating organ to study, and if you think about it, and you pay attention, it beats typically every second or so. So it's beating 100,000 times a day, 35 million times in a year, and in your entire lifetime will beat really an uncountable number of times. But what is the heart? It's essentially a pump. It's a pump that sits in the center of your chest and moves blood through your body. And so if we look at that, and I'll just show you this video to explain. So this is a video of the heart, and it has 4 chambers. It has these 2 chambers at the top called atria, and these 2 chambers called ventricles. And what happens is the blood comes from your body without oxygen after your body has taken the oxygen and enters the right side of the heart here. This is called the right atrium. And then it goes through this valve into the right ventricle. And then the right ventricle, which is one of the 2 main pumping chambers of the heart, pumps that blood into the pulmonary arteries, and then that goes into your lungs. And then in your lungs, the carbon dioxide is taken out, the oxygen goes back in, and then the blood goes back to your heart, into the left side of the heart. This is the left atrium, goes through the mitral valve into the left ventricle, and then the left ventricle pumps that blood out into the aorta.
What is the aorta here?
You won't see the aorta here, but this is the aorta here. This big, I can stop that, but I'll show you in a minute, just the next picture. So that's how the heart works. And there are many diseases of the heart, and I'm not going to get into all the detailed diseases of the heart, of course, because we don't have time for that. But these are images that show. So these are images of a CT scan here. You're asking about the, I think, Anubhav. That's the aorta right there. And this is the right side of the heart that I showed you. This is the left side of the heart. This is a CT scan. You can see the kind of detailed anatomy that we can see with the CT scan. This is an MRI scan, which is particularly useful when we're trying to evaluate the heart muscle. You can see the muscle of the heart here pumping, contracting and pushing the blood out. These are the valves you can see here. And this is the right ventricle here that's being evaluated. So these two techniques allow us to make diagnoses of the heart of a whole range of different conditions, whether that's the lining of the heart surrounding the heart muscle itself, the valves, the aorta, the aortic root, which is where the aorta starts. Any of those conditions can be diagnosed with this type of technique. But I want to focus on the most common disease. And the most common disease of the heart is of the blood vessels of the heart itself. And that's what we think of as heart disease when we think of heart disease. Heart disease is really disease of the coronary arteries. So the coronary arteries are shown, these are images from a 3D CT scan. You can see these lines that are on the surface of the heart. There's one there, I'm outlining another one here. And then as we come along, you can see this line here. So those lines, those squiggly lines that are sitting on the surface of the heart, those lines, they're tubes basically, that come from the aorta, the main artery of the body, and provide blood supply to the heart muscle itself. So they're very important. If your coronary arteries are blocked, your heart will no longer function. The blood will not reach the muscle of the heart. The muscle of the heart will starve from oxygen and will no longer function. So what do we mean when we say coronary artery disease? So coronary artery disease is disease of these blood vessels. So this is a blood vessel, and you can see normal blood flow coming down through that artery wall. But coronary artery disease is when there are blockages in the vessel itself, and the passageway for the blood gets narrowed, what we call the lumen of the artery gets narrowed, and you can see how reduced that lumen is compared to the plaque that is formed in the artery wall. And when that blockage happens in the artery, or when that narrowing happens in the artery, and you exercise, yes, please.
If you don't mind.
Yes.
If anybody has a question,
By all means.
any in between, please do ask him, stop him and ask the question.
Yep.
Because otherwise, when he goes away at the end, he may not be able to recall which slide, etc.
No problem.
Feel free.
By all
That's
means.
okay with
By all,
you.
of course.
I would certainly like to ask, why does the plaque get formed?
You ask an interesting, very interesting question. So atherosclerotic plaque, there's various different theories, but the basic theory is that there's an injury to the lining of the vessel wall, and that can be caused by a variety of factors, either inflammation, smoking, cholesterol, and there's an ongoing inflammation and healing process where the plaque builds up over time. So in fact, atherosclerotic plaques can be seen in people in their 20s and in teenagers. Very early little fatty streaks in the vessel wall. It just builds over time. And there are various causes. There are many different risk factors, as you know, for heart disease. I'll get to that in a minute. But it's basically an inflammatory process where there's an ongoing rupture and healing of the vessel wall. And there's macrophages involved. There's a deposition of different, the plaque can bleed inside itself, causing enlargement. So it's a really complex cascade. I didn't want to get into that in detail, but suffice to say that there is a process by which that happens, and it starts relatively early. So when you have those blockages and you exercise, you can experience what's called angina, where there's a reduction in blood flow to your heart muscle compared to what it needs under the state under which it's operating. So that's one type of problem that can happen from coronary heart disease. The other, of course, is a heart attack. And a heart attack is different from angina because what happens in a heart attack is there's the plaque here, and I'll just play the movie. So what happens is the plaque actually acutely ruptures. So there's a little lining of the plaque here. It's a little fibrous cap of the plaque. When that acutely ruptures, a blood clot forms right on top of that plaque, and it can completely block off the artery. And when it blocks off the artery completely, as you can imagine, there's no blood flow then to the heart muscle that that artery was previously supplying. And that's what causes a heart attack. So there's two different processes. One is more chronic, which is angina, and then this is more acute, which is in the setting of an acute vessel occlusion. So, yeah.
Amongst Indians, the plaque formation basically is related to or attached to dietary habits. How far is it true?
So I'm going to get that.
Okay.
Actually, you just introduced my slide. So thank you kindly. So it's very true what you just said. There's a 30,000 patient study done by Dr. Salim from Hamilton, who's a legendary leader in this field. It's called Interheart. He examined 30,000 people from all over the world. And he found that Indians have a 5 to 10 year earlier occurrence of coronary artery disease than the Western population. And why is that? People always thought, oh, there's a genetic predisposition. Indians must be, they're sitting ducks for heart disease because of their bad genes. But his study conclusively proved that that's not as much the case. What is the case is the prevalence of diabetes, of abdominal obesity, that's fat around the abdomen that's a problem, high blood pressure, abnormal cholesterol, poor diet, particularly lack of physical activity, and also smoking. So the risk factors, which these are for heart disease, are more common in Indians, causing the higher prevalence. And that was shown in that 30,000 patient study. So that, yeah.
Sorry. But doesn't the Western population, they also smoke? They are also eating so much of McDonald's and high cholesterol items. They also have high blood pressure, so why only?
So for Indians in particular, diabetes is more common, definitely more common. That may have some genetic predisposition. That's definitely a risk factor. High blood pressure also tends to be more common. So, but I agree with you, that was the previous thinking, but this study has shown that it's not so much that Indians have the same risk profile as the whites and they get more heart disease. It is because we tend to have a worse risk factor profile than whites on the whole. So that's what this study has shown.
Dr. Seth,
Yeah,
in the previous slide, you said this big study was done
yes.
by Dr. Salim Yusuf. Would you happen to remember what was the mean age at which heart attacks occur among Indians?
I don't have that number off the top of my head. But, the average age would be around 50, 55 for Westerners, so I presume it would be mid-40s to 50. Yeah. And certainly in Indians, we see coronary disease and heart attacks at a much younger age in general, irrespective of and presence of atherosclerosis at a younger age as well.
And that's not saying cardiac disease, coronary disease starts. You're saying heart attacks start.
Correct. That's right. So manifestations of heart attack will be in that.
45.
Well, I don't have that number exactly. I would say in the 45 to 50 year. Yeah.
Certainly if it's
Yeah.
cardiac.
That's right.
So one of the reasons I came across was the Easterners had smaller diameter on the vein versus Westerners evolved and they had.
Yeah, again, these genetic theories and predisposition theories may have some truth to them, but the bulk of the truth lies in the risk factors. That's the bulk of the truth, and the predisposition lies mostly with the fact that people have a greater prevalence of these various risk factors. But let me continue, and we'll. So when, yeah.
What do you qualify poor diet?
So let me again, maybe what we'll do is, here's my suggestion. You're asking questions that I will address. So I would request maybe you can just keep them, write them down, and then let's get through the talk.
I'm sorry.
No, because you're anticipating. It'll work better for you so that we can have the flow. So, these are results from another study by Dr. Sonia Anand, who said that in her data, that again, deaths from coronary artery disease are more prevalent among Indian men and women. And I think that's really important point I want to make with this slide, is that we tend to think of heart disease as a male problem, as a men disease. It's by no means limited to men. Women are equally affected, particularly after menopause. So it is something that as an Indian community, both men and women, we would be concerned about.
Thank you.
And then if you look, this is, I talked about some of the Canadian Indian statistics, but in India itself, India is facing a true epidemic of heart disease. And that's because of changing lifestyles, urbanization, increased fat and sugar content in diet. And these statistics are in some ways just unbelievable. So almost a third of deaths in urban areas attributable to heart disease. They have 4 people dying every minute of a heart attack. 25% of the people between 25 and 69 will have deaths because of heart disease. So it's really, I mean, globally speaking, India is a source of really a heart disease epidemic, and it's something that needs to be prevented if at all possible. So how do we prevent? So some of the questions were related to this. So these are really the pillars of heart disease prevention. Diet, exercise, the 2 things we can do the most about in our lifestyle. Smoking, of course, is terrible, and if anybody here is smoking, please stop. It's really not, it's definitely a terrible habit. High blood pressure, diabetes, and cholesterol, all to be treated with medication.
Isn't hereditary a factor as well?
Yes, no question, hereditary is a factor, but you cannot prevent your hereditary traits. So we don't get to pick our parents, let's put it that way. So we'll move on. So diet. So diet, a lot of talk about diet and what's the best diet and this and that. But at the end of the day, we've come down to a sense that the Mediterranean diet is very important. But what does a Mediterranean type diet involve? It involves, sorry, let's back up for a sec. It involves a core diet focused around the base of that pyramid, which is vegetables, fruits, whole grains, olive oil, beans, nuts, legumes, seeds, herbs, spices. That's the core of the Mediterranean diet. It's very different than the traditional Western diet that people eat, centered on white bread, meat, and those types of products. There is some other products that are included in that diet, typically in that part of the world, fish, seafood, etc. But meats and sweets are right at the top. And at the top of the pyramid means don't touch them if you can avoid it. So that's the core of the pyramid. It's the bottom. That's a heart-healthy diet. And so Mediterranean diet's popular, obviously, and this person's asking, Mediterranean diet's supposed to be very healthy. Can you write me a prescription for a vacation in Greece? So not included as part of the Mediterranean diet, of course. So this is Conrad Esselstyn, who's a physician who's written a book about a plant-based diet. So focusing our diets on plant-based vegetables, grains, whole foods. And he says, from a Western perspective, that diet is very extreme because that's not how people in Western societies have tended to eat. They've tended to eat a very meat-centered diet. But he said, that's not extreme. Having your chest cut open, vein taken from your leg, and sewn onto your coronary artery, that's extreme. So the diet is not extreme, the therapy is extreme, so follow the diet and avoid the therapy. And Bill Clinton, actually, who had a quadruple bypass surgery, he grew up, as you know, in the southern US and ate terrible diet, cheeseburgers and fries and all that sort of garbage. And as soon as he had the quadruple bypass, he actually became a vegan and followed a pure plant-based vegan type diet. And it was something that he says has totally changed his life. Again, from an Indian perspective, so this is Canada-India Foundation, and I would be remiss not to include our esteemed Prime Minister as part of this presentation.
All yoga lovers, yoga is one of the most precious gifts.
Can you turn this mic on so we can hear more? Let's try this.
All yoga lovers,
No, it's okay.
Can you hear that?
Yeah.
one of the most precious gifts given by the ancient Indian sages to humankind. It is said in the Bhagavad Gita, Samatvam Yoga Uchyate. It means yoga is a state of equilibrium and equanimity. Yoga not just a set of exercises that make the body fit. It is a passport.
So he said at the end, he said, yoga is a passport to health assurance. And I thought that was a very amazing comment, because when we go back and look at what did ancient yogic philosophy tell us in India? What did it tell us about, sorry. So what did it tell us? Well, as you know, some of you who are familiar with this, some of the knowledge from yoga, would know that there's 3 different types of foods that there's talked about in yogic philosophy. And the one that's most interesting to us is this group, the Sattvic type of food. And if we look at what that means, it's a recommendation for healthy living and prevention of disease, fruits, vegetables, harvested at the appropriate time, of course, milk from happy cows, sprouted whole grains, legumes, nuts, seeds, honey, herbal tea. Sattvic food should be fresh, mild, and consumed in moderation. Doesn't that look really familiar to the whole grain, whole food Mediterranean diet? So it's not shattering rocket science. We need to study the literature and understand what is the best type of diet to eat. It's, from an Indian perspective, it's been in our culture for a long time. We just have to pay attention to it and understand what it is that we should be doing. The other thing that we can do, of course, to prevent heart disease is exercise. And these are the American Heart Association recommendations for exercise. 30 minutes of moderate intensity exercise, meaning walking basically at a brisk pace, should be done 5 times a week, 5 days a week. And alternatively, if you prefer to run, you can do 25 minutes of running 3 times a week, or swimming, anything else that is more vigorous. And you can combine that with high intensity weight training type of exercises. Now, I know everybody here is busy. Everybody has a busy life, and it is very difficult to find time to exercise, and I'm no different. It's also difficult for me. So then I remember this cartoon when I'm what to do with myself and deciding should I exercise or watch television. It says, what fits with your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? So I'll definitely pick the exercising 1 hour a day. And it's certainly very important for health. So now let me move on to the more subject closer to what I do in my professional life, which is talking about a traditional diagnostic pathway and then how we're changing that in imaging. So from the 1960s onward, there's a basic technology that's been at the core of coronary diagnosis, diagnosing these blockages in the arteries. And that's the invasive angiogram. And some of you in the room may have had one before. But that technology arose in the 1960s and really hasn't changed much since then. But it is the center point of how physicians manage coronary artery disease. So if there's a suspected blockage, the ultimate test that can be done is the invasive angiogram. But it's an invasive procedure, and so I'm going to just show you what that actually looks like. So this is a coronary Ct angiogram being done, and the patient is admitted for the day into the hospital. So you go in the morning, you have to lie in that, this is just a graphic of the catheter. You have to lie on that bed. You're awake, but you may be a little bit sedated. You're awake, lying there talking to the physicians. And what happens is actually a puncture. That catheter is inserted right into the groin itself, into the artery. And then they feed a tube all the way up to the root of the aorta, and that's where the coronary arteries are. And then they inject the dye into the coronary arteries directly. So the catheter is put with the tip in the artery that I showed you, and then the dye is injected directly into the artery to make a diagnosis. So this is what a coronary, so this is the 3D CT images I showed you. So this is the artery that we may be examining, and if we look at what a catheter angiogram looks like, this is the catheter tip. This is an X-ray picture. There's a catheter tip, and you can see there's a flash of that dye because the doctor is injecting the dye into the arteries, and then the picture shows up of the arteries. So this used to be the only way to make a true anatomic evaluation of coronary artery disease. This was the only way that we could do it. A whole day procedure in the hospital, risk of a groin puncture, risk of all of those invasive complications that can potentially occur. So how did we used to use, what was the way that, say, 15 years ago, if you had symptoms of chest pain, the busy executive here, symptoms of chest pain, what would have happened to you? And still happens, I would say, today to some extent, but it's a practice that is phasing out in terms of prevalence. So what happens? The next step is you see your physician. And then after you see your physician, the next step after that is they typically order tests. So they'll order an exercise test where you you run on a treadmill and they're checking for changes in your ECG, your blood pressure, heart rate, symptoms, things like that. Or they'll do a perfusion test where they're injecting a dye into your vein, but then they're looking at the blood flow to the heart. And they're looking to see are there any areas of the heart that have decreased blood flow. It's not a perfect test. It was what we had available to us in this era. And then if any of those are abnormal or there's still some concern about your symptoms, then you proceed on, you see a cardiologist who then will make a decision to order an invasive angiogram, which was just what I just showed you, the video of what you would have if you hold a procedure in the hospital, et cetera. Now, that invasive angiogram, despite all of these steps that have been done before getting there, is actually, in the literature, only abnormal a fraction of the time. So 40% of the time, despite having all of these other tests beforehand, you get to the invasive angiogram and it's mostly, or 40% of the time, is normal and minimally diseased. So this is really not a great way to be practicing medicine, to put people through all of these steps, to subject them to an invasive angiogram, and then still have a result where most of the time that test, or a significant portion of that time, that test was unnecessary. So physicians have dreamt for a long time about a mountain peak where there's your invasive catheter angiogram, 1960s technology, but working up that mountain peak, this would be the non-invasive angiogram. So if we can make a diagnosis to look at the coronary arteries completely non-invasively, where we don't subject people to the day in the hospital, to the risk of the groin puncture, to all of the complications that can occur from that, and the trauma of having that done, that would be the mountain peak. And that mountain peak, when I finished my training, was just barely in view. And now I would say we're at that mountain peak because we've seen tremendous progress in both technology and our understanding of the science behind that, that we now have really a completely non-invasive angiogram that is in ready medical practice. So this is the way we do it. It's using a CT scanner. So the CT scanner, as I told you earlier, is an expensive piece of equipment. In Ontario, they're found only in hospitals. And when we look, if we open it up, so this is the CT scanner opened up, you'll see it's actually pretty simple. So there's a lot of complex physics and stuff. I don't understand the computer and all that inside there. But basically speaking, it's a very simple technology. You take a X-ray tube here. The patient's lying in the middle of this donut. You shoot the X-rays through the tube, through the patient, and there's a detector on the other side. And that detector bank is capturing that information about how the patient blocked the X-rays, and then from that, we're getting the data that gives us the CT scan. So modern CT scanners, now, they rotate around the patient. So if you look here, there's the X-ray source on one side, the detector bank on the other, and as you're going through the scanner, the whole apparatus is rotating around you. And nowadays, in the scanner that we have acquired recently at the Trillium Health Partners, there are actually two X-ray sources, so one and two detector banks. So what does that allow us to do? It allows us to take pictures of the heart where we essentially completely freeze the heart motion. So the heart, as you know, is a beating organ. So taking pictures of it, as you imagine if you're taking pictures with a camera and your child is running across the room, you have to have a very fast shutter speed. So this effectively is the shutter speed. And because of those technological advances, we've been able to make coronary CT angiography an extremely robust technique. So I showed you the invasive angiogram. Here's a cartoon showing you the non-invasive angiogram. So you walk in for the day. You don't have to, it's not a day admission. You just walk into the CT scan department. You get prepared. We typically give you a beta blocker if your heart rate is too high. You lie on the scan table like that. There's an intravenous that's inserted, and that's the only invasive part of it that you have. We put on some ECG leads so we can tell where the heart is in the cardiac cycle when we take the pictures. And then The patient is, the table is raised, and the patient is then advanced into the scan machine. There's a scan machine there. There's a contrast here, which is injected as part of the scan that's set up. And it's done in a single breath hold. So the scan is done in a single breath hold, somewhere between 5, 6, 7 seconds, depending on the patient. And that's it. It's done. And then the patient comes back out. We take the IV out, and they go home. So that is how coronary CT angiography is done today. And as I said, it's completely non-invasive. It's a 5-second scan time. It's a relatively cheaper test than the perfusion test, which has been done in the past. And it allows ultra-high resolution images of the coronary arteries and detection of artery narrowing, unparalleled accuracy. And it's really the most accurate non-invasive test. So short of the invasive angiogram that I talked about, this is the best way to make a diagnosis for coronary artery disease and is growing in use.
The whole process.
I beg your pardon?
The whole process.
The entire scan time in the room is about 10 minutes.
Wow.
The actual scan itself is about 7 seconds. So these are the images that are generated, and then we take these images and we analyze them on a 3-dimensional workstation. So that is the diagnostic part of it. And these are the kinds of images that are generated. This is an image of one of the coronary arteries and an image of another coronary artery. So we can study those coronary arteries completely non-invasively with this technique. And this is a normal artery, which we hope to find. And sometimes we see these narrowed arteries where you can see that line has been broken because of the plaque buildup in the wall of the artery. So these are just 2 case examples. I've simplified them, of course. It's from a previous cardiology talk I gave, but just to give you an example of what we do, what we see. So here's a 62-year-old female patient sent to us with atypical chest pain, which means they have chest pain sometimes with exertion, sometimes at rest, sometimes walking up the stairs, sometimes not. So it can't be really characterized. What is it exactly? We don't know. The stress test that they did was mildly positive, but what does that mean? We don't really know. And the perfusion imaging was either they had a heart attack or it was a false positive. So you can see the diagnostic information available to the physician is pretty not very helpful. So inconclusive diagnosis. Do you send them for an angiogram or not? Well, we don't know. So this is where CT plays an essential role. So we did a CT angiogram and our arteries are totally normal, which is one of the best results we can get. So when we read a normal study, it's very gratifying because it means the patient doesn't have disease. And that's a big value for non-invasive imaging because you provide the reassurance to the patient, to the physician, that their symptoms are not due to coronary artery disease. This is a 56-year-old male patient, mild chest tightness with exertion. He had minor abnormalities on his stress test. His perfusion imaging was normal. But his symptoms happen with exertion, and I told you angina happens typically with exertion. So does he have a blockage or not? Well, we don't know. Again, the same problem, no conclusive diagnosis. So do you subject him to an angiogram? Well, we would have in the old days. But here he is, and there's a blockage in his right coronary artery. And so then he goes on to an angiogram knowing that there's a blockage in the artery. And there's the angiogram image. No, it's not playing. So there's the blockage you can see in the artery, exactly matching the CT scan. And then he has a stent and angioplasty to treat that. So CT scan has played an essential role in helping to make the better diagnosis and better treatment for patients. Now, there was concern originally, because I told you of the x-rays, that this is actually going to cause radiation, excessive radiation exposure. And in fact, there was a New York Times article in 2008 about the fact that there's high cost vis-a-vis the radiation that is being given from these tests. And it was true, definitely. Since I've been practicing this since 2004, I've been through this era when CT scanning was a very high dose technique. And we did not perform it in women less than 55, 60 years of age because of that problem. So this is radiation dose. This line is your annual background radiation, which is around 2 to 3 millisieverts. And a heart CT at that time gave a huge dose, 10 times the annual background radiation. So in the early days, we used it very selectively because we did not want to give excessive radiation to make a diagnosis when we could do it in other ways. But that has completely changed. So now, that was in 2007. Now in 2018, this is the kind of dose that heart CTs are generating. So really the same as your annual background radiation, not of much consequence to anybody, including younger women, where we worry about the irradiation to breast tissue. It's not an issue. And it's much less than any of the other tests that are done for coronary artery disease. So in medicine, of course, it's a nice fancy technology. We don't just adopt it because it looks nice and it generates pretty pictures. We do science and we prove that it actually works. And that's two studies I'm just going to very briefly mention. This was a 10,000 patient study called the PROMISE trial. And they gave access on half the study, one arm, to people. They didn't give them CT, and the other half, they gave the doctors access to CT. And when you gave them access to CT, the angioplasty is more than doubled because you're picking up disease that you were not seeing previously. Similarly, with bypass surgery rates doubled. You're picking up disease that you were not seeing previously. And this was a Scott Hart trial done with 4,000 patients in Scotland, looking at what happens when you give doctors access to the information from CT scanning. Well, it totally changes how they give their medication regimen. So if they don't have CT between their initial visit and when they come back and see the physician, there's a very small change in how they treat those patients with medication. But if they have access to the CT scan information, 23% of the time they change the drugs they give the patient. Either they stop the medications because there is no heart disease blockage, or they give them medication because they need it and they have confirmation that there is actually disease. So the literature has become so powerful now and so strong in terms of identifying the role of CT scanning. The United Kingdom went as far in 2016, and these guidelines are to all of their physicians in the United Kingdom, for diagnostic investigations for coronary artery disease. The first thing you should do, forget the stress test, forget the perfusion test, forget everything else. The first thing you should do, this is United Kingdom guidelines, is a CT scan of the heart. So we've talked about from the periphery of medical care to right to the center. I told you at the beginning that's what's happening in imaging throughout. Well, it's certainly happening in coronary artery disease. And the United Kingdom is looking at trying to increase their access to CT scans by 7-fold to meet the demand that this is going to generate. So this is the old pathway I told you about. We've talked about this. This is how it used to be done. This is what the future is going to look like. So there's your patient. They see their physician. And then the next step is a coronary CT angiogram. So everything else gets removed from that pathway. And then from there, if you're normal, you have almost 100% certainty that you're normal, and you don't need any further testing. You can stop. If you identify some disease in the arteries, you can be treated with medication, and no further tests are required. And if you identify potentially significant narrowing, then you proceed to the additional testing, the angiogram or perfusion test, as the case may be. And this is going to cause, this will result in less cost to the healthcare system and a faster and more accurate diagnosis. And so we are seeing that. So for CT scanning or CAT scanning, we are seeing immense increase in demand. So this is our case volume at Trillium Health Partners, and I know some of you must be from the Mississauga area. We're seeing it like an exponential growth pattern in demand for coronary CT angiography as we move from the periphery of medical diagnosis to the center of medical diagnosis. And I'll end with this little cartoon. It says that this is for CAT scanning department. He says you have to expect some cutbacks with the government health plan, and there's the cat doing the scan. So we actually don't use cats for the CAT scan, but certainly we struggle with meeting demand for advanced care like this in the environment that we practice. So this is what I've talked about today. We talked about diagnostic medicine, heart disease, the heart, Indians in particular, prevention, and then the diagnostic pathways and how they are changing. I want to just end with one final comment, which I know Anil Bhai has talked about in the past, is the Trillium Diwali Gala. I'm on the organizing committee, as is Anil Bhai, and there's a number of others, I'm sure, here who may be involved. But it's a plug to get involved. We try hard as physicians to provide the best type of care we can in the community, but we really struggle with access to the latest equipment. And this event in particular is to support the stroke surgical program. So with that, thank you for your attention. Yes, please.
There will be lots of time for questions, just one second.
Dr. Seth, a very impressive lecture. Really appreciate that. Just one question related to what you said about National Health Service in UK.
Yeah.
Is now proposing this to be the first line for diagnosis. Is that the case also in Ontario, or just with the practice of certain specialists like yourself, that it's covered under the health plan and it's being utilized by everyone as the first line for diagnosis?
Yeah, you asked an excellent question. So medical practice never changes on a dime. So physicians, as you know, you may know, are very notorious creatures of habit. They do a certain thing a certain way, and it takes a lot of effort to change it. And that being said, I can speak to our region because I practice in this whole region, Halton region, in Oakville, Mississauga. So 1.2 million people in this region. And the physicians are ready to change. The problem, of course, is, and they are changing, as you can see from the demand that we're seeing, but access is an issue. We always struggle with that because the wait times for this test, practically speaking, are on the order of months. And because of the referral volume is so high. So, you know, you're faced with the triage of should the patient wait 3 to 4 months for the exam, or should you do something else? So I would say the capacity will catch up over time. It's just that as technology has advanced so quickly, the system hasn't prepared itself for that. We're unquestionably moving that way. And we are working in our work at the hospital to find ways to take the existing resources and put far more people through them in a given day. Because as I told you, the capacity of the system for these machines is difficult because they're so expensive. But if we can use a scanner, instead of putting 20 people through a day, put 60 people through a day, you can achieve, you know, much better access. But, you know, I think the guidelines in the UK are the first internationally. In North America, the guidelines do not yet state this, but the literature evidence is well recognized. And I think a lot of physicians now are moving their practice in this direction where they can and where access permits. Yes?
How many hospitals have this type of machine, 64 slides?
I would say all the major cardiac centers have very active practices. We're the highest volume in Ontario in Trillium for what we do. But Ottawa Heart does, Toronto General does. So any place where there's a heart center attached has typically quite advanced practice in this. But it's the other smaller hospitals, no, I would say don't offer that.
Hi, Doctor.
Yeah.
2 years back, my father had an angiography followed by an angioplasty. I was with him at the hospital. I observed that before the angiography, he was given some pills, some medicines. With this process also, is there any medication which is to be taken before the scanning or?
Yeah. Excellent question. Yes. So we don't need any medication for the scan itself. What we do need is the patient's heart rate to be slow. So as I explained to you, we're taking pictures of the heart. So if the heart is beating very fast, there's too much motion. So we want the heart rate to be slow. And for that purpose, we give typically beta blockers, which is a heart rate slowing drug. We can give a calcium channel blocker. We do that in the CT scan department. So if somebody comes and their heart rate is 55, they proceed right to the scan. They don't need to do anything in advance. If their heart rate is higher, then we give them the medication. Our nurses look after them. And then once their heart rate reaches where we need it to be, then they proceed to the CT scan.
Angiography, as I understand, is done on a cath lab. So once the dye is put in, and then if an angioplasty is required, it is done right away before sealing it up. So with this process, is there a waiting time before the angioplasty, if it is required, or you can do it right away once the scans are available?
Yeah, so it's not, of course, done the same day. But the wait time for angioplasty and angiogram is relatively short, a couple of weeks. This is a much longer waiting time. So if you have this test done and it shows something abnormal, typically the patient will go back to their cardiologist who ordered the test and then have that discussion, and then they'll proceed to the angiogram relatively quickly. So that's, yeah.
Initially, you mentioned about CT scans.
Can you get the microphone, please? I think I'm going to moderate that.
Yeah, initially you mentioned
Excellent. I didn't have time, of course, to get into that in the talk, but I'm happy to answer it. So MRI is, it's a very different technology. So it uses no radiation, and it's a very powerful magnet. So the patient lies inside the scanner, and we take pictures with that technique. MRI it's a slow scan process. So as I told you, the CT scan is done in 7 seconds, 10 seconds. An MRI scan will take 45 minutes. So it's much longer. So we use it really for problem solving. So for example, if we're not sure if the patient has had a prior heart attack, if we don't know that, or if we want to know what's the extent of damage to the heart muscle, MRI is excellent for answering that question. If we want to know if the heart muscle is abnormally thick, MRI is useful for answering that. So really, we use it primarily to solve problems that other techniques can't diagnose. It's really the last sort of, it's a really third line kind of test where we do an echocardiogram first, we might do a CT scan first, and MRI comes right at the end for diagnosis.
The causes of coronary heart disease, like diabetes, high blood pressure, smoking, high cholesterol, that can be controlled. Those are controllable. Hereditary is something that cannot be. You are just born and you carry on. Are there any studies conducted to change the genes of the parents so that the offspring are free of coronary heart disease?
Not that I'm aware of. I don't know if it's a little bit of a medical ethical dilemma, but.
Indians, when they are in India, they don't have heart disease. When they come to the Western countries, all of a sudden, they have blood pressure, anxiety, tachycardia.
They don't get detoxing.
Well, it's actually no. I would say in rural India, perhaps you're right, but in urban India, the rates are just the same as they are here. They're no different.
Is it genes mutation and marriage is taking place within the caste? That also factor?
I don't know, perhaps. But as I said, the majority of the explanation is in the risk factors. So if you treat the risk factors and practice the level of diet and exercise that you should be practicing, and make sure all the risk factors are treated, then you probably deal with 85–90% of it. And maybe there's a small part that is related to the tip factors that you talk about.
What is the color Doppler?
Color Doppler is a flow assessment technique. It's used on an echocardiogram to see whether the flow is going in the right direction, or whether there's any regurgitation through the valve. It's used to assess flow in an echocardiogram.
Still it is in use?
Yes, of course. Yes, I talked about ultrasound at the beginning. So ultrasound of the heart or echocardiogram is used very commonly. And it's a sort of a basic test that you would do just to see a basic assessment of how the heart is beating.
Dr. Sheth, I can add something to you. Some of the questions that were asked here, I personally gone through the 1966 or 60 model. Started with the treadmill. The whole thing was cyclically showed. I went through the whole thing. After the angioplasty or angiogram, they decided to do the angioplasty on me. I got 2 stents here. Simply, but it took almost a year before I could get to that point, from day 1 to day end. So Trillium is still, Ontario is still on the 1960s path.
Yep, for the most part.
Unfortunately, the wait times are getting. Go ahead, come on.
Just want to find out what alcohol and red wine affects the heart tissue.
Yeah, again, I'm not too familiar with that. I certainly know that in small moderation, there's no harm, and there may be some minor benefit. But again, it's a little bit outside of my core area of expertise, so I don't want to venture to answer that question and give you a green light.
Yes, Rajesh.
Yes, exactly. Exactly.
Yes, I want to ask you a quick question about preventive measures. There was something that good diet, exercise. In your opinion, how many hours of exercise, say, walking and a little bit weights and all,
what would be the ideal in every time? It was said you said it was
Typically, the recommendation is half an hour or so of walking, brisk walking every day. If you can do that, at a minimum, that should be done. But the more you do, I mean, you don't want to be walking your entire life, right? You have to still live. So the point is to find a balance where you're doing enough physical activity that you are benefiting your body. And those guidelines are based on population studies where they look and see where is the benefit for exercise achieved, and this is what the recommendation is. So 5 times a week, 30 minutes of not sort of leisurely stroll, but of a good brisk walk is the baseline recommendation.
Regarding cholesterol, we hear new theories every day that, sometimes they say that that's not the main culprit which is involved in plaque formation. And the body produces more cholesterol than the food intake. Is that true?
Certainly cholesterol remains a risk factor, and there's 2 different types of cholesterol. There's a good cholesterol and a bad cholesterol. I don't want to give the impression that it's not a risk factor. Certainly it is a risk factor. And if you have abnormal cholesterol, you should have it treated. So I'm not too familiar with this theory that you're talking about, but certainly the basic things that you want to look after are what I put on that slide. Make sure that if you have diabetes, that gets treated and managed properly. High blood pressure is very important. And of course, cholesterol and other lipids. There's triglycerides and other things that should be treated as well. Because the evidence for that is based on large population studies where you treat that particular parameter to a certain level and patients benefit. So the science there is pretty solid.
If a patient has blockage in the arteries without angioplasty, with lifestyle changes, is it reversible? Or what I have heard is that with lifestyle changes, when you lose weight and you have a better lifestyle, the pressure on the heart is much less. So the blockage doesn't go on its own, but you are able to have a comfortable life with the blockage.
Yeah, I'm not sure there's been a lot of good data on that, but there certainly is one person who's worked in this area. His name is Dr. Dean Ornish. You can look him up. And he's written a book called Using Diet to Prevent Heart Disease. But he recommends a low-fat, pure plant-based diet. So basically it's vegan diet, but low-fat vegan diet. And he's shown that he can actually reverse atherosclerosis in the coronary arteries. But it's a difficult diet for people to follow, a lot of people. But I think there is some evidence that it can be done. I don't know if it's hard to comply, whether people can do that on a population-wide basis. I have my doubts. Yeah.
That's a question. Before both of you ask that question, I just want to say a big thank you to my Sri Lankan friends here. This is the first time I have a Sri Lankan team representing their country here. So I just want to say, please, if you have any questions, because you are also equally having the same problems that we Indians face. So please do feel free to ask questions. But anyway, the microphone here, please to Girish.
They say yoga is a breathing exercise, and in the recommendation 30 minutes walk. Will you call it a physical exercise, or with that you are controlling your breathing with the breathing exercise?
I would stick with the walking recommendation as a baseline. So I wouldn't substitute yoga for walking. And I don't think at least in the Western literature, the understanding of the value of yoga is probably not very well understood. We know from just cultural practice that it is certainly very valuable. But I would do it I would not substitute, because as I said, those recommendations are based on solid studies and data that says this is what, if you do this, there is a benefit. So I would work with that and then add on top of it whatever you have time to do.
Dr. Firstly, the excellent talk.
we really care about the cancer in the heart. My question is regarding basically, in the best of my years, we've been told by doctors, avoid it. Now today I came and putting it even in the coffee, and they say take it. What's your stand on this?
Again, you're asking something that I don't professionally have that much knowledge about. I can tell you personally. I think a certain amount of fat is certainly acceptable. I wouldn't excessively consume anything. But to say that you absolutely should not have it is probably a little bit extreme. But there may be some value to it. I don't know. I don't think it's been that well studied to know whether the desi ghee has any particular health benefits. But again, there's some humility when you look from a Western perspective, because a lot of the practices that have been done in India for a long time are now showing to have benefit. I mean, look at yoga, look at meditation, look at the diet that I talked about. If you talk to a Westerner 100 years ago, and you showed them that Sattvic Yogic diet, they would say you're missing all of these essential nutrients and vitamins, and well, you're going to kill yourself eating this. And now that's what they're recommending themselves. So my point is that I don't know, I don't have any firm knowledge or data on it, but I'm always hesitant and a little bit humble in questioning historical practices that have been done for thousands of years and may have some value to them that we don't know.
One last question. I think Anil mentioned about wearable technology, and I don't think you mentioned anything. Like I was hoping that you wear something and you have a heart attack and you say, oh my God, I'm having a heart attack. That kind of.
Yeah, I mean certainly it's a research interest of mine. Anywhere near there yet, but we're looking at using a wearable vital signs monitor. So one of our issues is, as we're trying to move people through the CT scanner, we can only have 3 people being prepared at one time because we have a limited number of monitors and, frankly, limited physical space. So I don't know if any of you have been to Trillium Hospital, but the physical space is, atrocious. There's no room. So, we're looking at using sort of wearable types of monitoring system where we can, instead of having people in stretchers, we can have them in chairs. And then we can prepare many more at one time and have them go into the scanner much faster. So that's how we're using it. But I think there's a lot of different potential for wearable technology in medical care, for sure. I just think it's my area of expertise. I'm not sure that much.
Is it true that there is a blood test which can detect whether you have had a heart attack in the last 4 hours?
Yes, of course. I mean, that's troponin. That's the standard blood marker that's used.
Doctor, this is a Sri Lankan question. Yoga is good for health, also laughter also good for the heart, they say. So I saw that the patient going into the machine is look like Indian. Is it done purposely?
It wasn't done purposely, but I found that I didn't make that. I found that off the internet. Coronary Ct angiography in India has taken off immensely because their patients pay for healthcare and they can drive demand. So in India, it's common. So there's a lot of education videos just showing how that works. So not a coincidence, but that's why it's
Doctor,
there.
the damaged heart muscles, it can be replaced?
Not very easily, no.
There is in Toronto some few years back, one Indian doctor only. So it has really come in practice or not yet?
Yeah, not that we're using at Trillium, certainly, but yes, there is talk about injecting stem cells into the heart muscle to see if you can cause it to regenerate. But again, probably more in the research realm rather than in clinical practice.
What is the difference between angioplasty and bypass? How would you explain?
Sure. So angioplasty is when you put a tube, catheter into the heart artery, and then you put a balloon at the end of that tube and just inflate the balloon. It's like a little cylinder. And it inflates and it squishes the vessel wall, so the plaque gets squished, and then they put a stent, which is a scaffold, inside the artery to keep it open. That's angioplasty and stenting. It's done as a day procedure, and really can be done at the same time as an angiogram in most cases. Bypass is totally different, of course. Bypass is where veins, either typically from the leg, or the radial artery, which is in the arm, or there's two arteries inside the chest which don't supply the heart, called the internal mammary arteries. These different vessels are used to bypass the area of blockage. So there's the one end of the artery is in a normal, starts normally, either from the aorta where it's sewn in, or in the case of the mammary arteries, right from where they normally exist. And then the other end is attached to the artery after the blockage, so that it provides supply of blood to the heart muscle from the blockage onward. So
Why would you recommend one to the other?
I certainly don't recommend that. That's the job of interventional cardiologists, but they would make that decision based on how the angiogram looks. So if, for example, there's a pattern, typically bypass surgery is done if the left main artery is involved, which is there's two main origins off the aorta. The left main is one of them. If that's involved, that's a reason to do bypass. Or if there's disease in all three vessels of the coronary arteries, then that's another reason to do bypass.
Sometimes with a single blood test, the physician put us through Taiwan, cholesterol for the rest of our life. Is that something can be prevented by taking those medicines, doing some other food habits or make for exercise like yoga, or should we be on those tablets for the rest of our life?
Well, so the decision to be on the tablet is based on your blood level for whatever that parameter is. So if you need, and again, the targets for that blood parameter, say cholesterol, the target for where that cholesterol needs to be is based on large population studies. So there's evidence that if your cholesterol is above that level, you're at increased risk. So certainly you should treat to get your cholesterol down to the level that's targeted. But if you can improve your lifestyle and lose weight and do all those things, people's cholesterol does drop. In fact, diabetes can be better managed if you lose weight. So, it both work together, but certainly I wouldn't advise to not take medications that a physician has prescribed because they are definitely life-saving, no question about it. Yeah.
From a diagnostic perspective, how would you tell the difference between blockage in the artery, a normal blockage, how would you tell the difference between a normal blockage in an artery and a coronary artery dissection?
Question. So typically we don't see coronary artery dissections in the CT scanner because when they occur, people go to the hospital emergently. So typically when they present like that, they come to the hospital like that, they go right to the cath lab. So our diagnosis is more on outpatients. That being said, you can see in the artery, a dissection tends not to be focal. So blockages affect just a small portion of the artery, and then you'll have a normal segment, and then you can have a disease segment. A dissection will spiral down the artery and will typically show abnormality all the way through. So that, we have seen people after they've had the dissection treated and followed them with CT scans, but we typically don't make the initial diagnosis. That's made in the cath lab.
There was a second part to that question, which was, you talked about the blockage as a result of scabbing and the healing process and scabbing again. So what does cholesterol have to do with that scabbing process, and how are the two interrelated to each other?
Well, cholesterol is one of the components that builds up inside of the vessel wall and is also one of the factors that can cause disruption of that intima. And as it deposits into the vessel wall, it builds over time. It also incites an inflammatory response. So the body sends macrophages, which are inflammatory cells, into the plaque thinking that it's an injury or it's an infection in a sense. And then it fights it, and then there's an inflammation, and then there's again weakened. So it's a whole cycle that happens over and over and over again. And so cholesterol is one of those factors that causes that initial inflammation and damage to the vessel wall.
Any questions? I have one. Doctor, I had a chance to interview Bob on the matter, or what we call it, a truly incredible radio show that I was doing. And in that interview, which I did in a long pause, the tables that he had. He said that from the moment of 9/11 call to the table, Trillium has a record that the patient was on that table in less than 6 minutes, 6 minutes and change something, seconds. So from wherever they had 9/11 call went through, The patient was picked up from the home to that table was 6 minutes in shade. How does your role fit in at such a time, because that patient was having obviously a heart attack and was brought on the table? So how would you fit in at that time, because there was already diagnosis done, but yet the doctor has to save the patient?
So in that setting of an acute heart attack, we don't spend time doing a CT scan. They go straight to the cath lab. Because if there is something to be treated immediately, you don't want to waste time achieving a non-invasive diagnosis when you need the treatment. Imaging does play a role in the acute setting where we worry about the damage to the aorta. So there, people sometimes have a condition called aortic dissection, where instead of the coronary arteries, it affects the main artery of the aorta. And their CT scan is essential, and that's what we do after hours, of course, anytime it's needed to do that. But not so much for acute heart attack. That's entirely cath lab based.
Well, one more question.
What are your thoughts on other invasive procedures other than the heart? Right, there are colonoscopies and other. What are your thoughts on those?
Yeah, so imaging is playing a very increasing role in all of those areas. So there's CT colonoscopy also that's done typically, again, more in places where you don't see the full colon because of whatever reason on a colonoscopy. There's no guidelines that say that's the way to go, but there are alternatives available for many, many different areas. And it's a judgment in terms of, are you suitable for the standard approach, or is an imaging alternative better for you? And in some cases, like I've shown here, the imaging approach is moving into the center of the care and being used as the mainstay. In other areas, it's more as a problem solver. In CT colonography, at the moment, it's more of a problem solver, because typically when you do a colonoscopy looking for polyps and for disease, you want to take a biopsy sample right away. And that's why it's better to do the colonoscopy first, because then you can get the biopsy done at the same time. Typically, it's a very safe procedure, typically.
So colonoscopy coming as a routine preventive approach by many doctors, and doing invasive procedures unnecessarily also cause other damage.
Yes, agreed. Yeah.
Right. So.
With the CT colonoscopy as an example, again, I don't practice that area, but I can tell you, because I have some knowledge of it, that the prep that's required is the same. So you need to do the same horrific drinking and having diarrhea for 48 hours. So it's the same process. So most people would say, well, give me the definitive test. If I have to go through that whole thing, then do a CT colonoscopy, and it doesn't answer the question. So it's a judgment call. I agree with you that there's a risk, but the risk of colonoscopy is very, very low. It's not a very risky procedure.
Doctor, it is said that after this bypass, again scaling, the rate of scaling may be more than the regular, with the chances of getting again blocked for the second time. Why it is so?
I'm not familiar that that's the case. I mean, what we typically do after somebody's had a bypass, if they have symptoms again, then we can do a CT scan to see if all the blockages, all the bypass grafts are open. But I'm not aware that there's an increased risk of atherosclerosis after bypass. Yeah.
One more.
Probably last one here. So there are two schools of thought, especially with the stent. You're introducing something that's artificial, right? And you're opening up the affected area. Has any studies been done to talk about the longevity of that particular line of treatment? Because if you're creating having an artificial something in there, is it actually going to irritate it more, and therefore the body's going to think, oh, there's something here, let me go attack it again and get rid of it, and in fact make it worse?
Yeah, it's a great question. Stenting for coronary artery disease has been done for 30 years now, and there's good long-term evidence that it's a very effective treatment. People can develop in-stent restenosis, blockage of the coronary artery stent, but I don't have the exact numbers, but it's a relatively infrequent occurrence. So yes, the body does recognize it as a foreign entity, but it tends to form a lining around it and the inside, where then there's no reoccurrence of disease. It's a re-endothelialization, as it's called. But some people, of course, it doesn't work, but it works in the overwhelming majority and has for 30 years. So it's a very good tip.
One more question.
Patients with controlled diabetes, erratic blood pressure, unstable angina, high cholesterol. What do you treat first?
Luckily, I don't have to worry about that. Remember the D and the R? I'm the D.
The reason I'm saying that, I find that the physicians are really sometimes the culprit. Such a patient is prescribed about 16 to 18 medications, including ASA, even
The physicians are just following their treatment guidelines.
Like statins are used like Tylenol.
Ramesh bhai, they make you people rich, the pharmacists. Ladies and gentlemen, I want to thank Dr. Tarang Sheth for an excellent lecture. Guys, give a big hand.
Thank you.
I want to thank Sudha and Mayank bhai. Thank you very much for the support you guys have given. And one last request to every one of you, we would like to hear more from you. What kind of presentations that you would like to hear from? We could try and arrange. So please do communicate with Sudha and or me. You have our email address, or otherwise CanadaIndiaFoundation.com, and you can connect with us any given time. Give us your recommendation, what you would like to hear from us in our new future speaker series. Thank you very much and have a great evening. Sure.